we'll go on to the PET, and I would request Dr. Chandrasekhar to introduce Dr. Mahapatra, and then we can have the discussion. Dr. Chandrasekhar.
Good morning. It's my pleasure to invite Dr. Mahapatra to give us some expert advice on how to use PET-CT in patients with heart failure. Very important topic. Dr. Mahapatra, please.
Thank you, Dr. Chandrasekhar. I think it's a deep midnight or early morning from Minnesota, and I'm very much thankful to you especially, and Dr. Nanda. You both are spend your time and lost your sleep and be there. Role of PET-CT in CHF. You all who know, as you have been hearing from the morning, that heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. Approximately 5 million patients in the US and 15 million approximately patients in Europe have heart failure. It is the leading cause of hospitalization in the elderly people. It is the leading cause of hospitalization in elderly people. Despite treatment advances, the mortality rate of heart failure has increased steadily. One of the best possible causes could be more number of patients are surviving myocardial infarction due to a better standard care, and consequently may increase number of patients who subsequently develop heart failure. Heart failure places a significant burden on patients and healthcare system. Imaging is widely used in decision-making in heart failure, not only in relation to left ventricular systolic and diastolic function. It can decide in the selection of medical versus surgical therapy, intracardiac devices in heart failure, and valvular heart disease. Further developments in the care of advanced heart disease, including stem cell therapy versus cardiac transplantation, device therapy to control remodeling, percutaneous valve intervention. The epidemic of diabetes and obesity will augment the existing epidemic of heart failure. Novel structural measurements. What are the measurements in the diagnosis and management of heart failure? As you know, major changes in the management of heart failure have occurred over the last 2 decades. It still remains a malignant disease. Patients present with extensive ventricular damage, whether ischemic or non-ischemic, to recognize and treat LV dysfunction. Various modalities such as CMR or MR, CT, tissue Doppler, 2D echocardiography stent based on speckle tracking, but nuclear techniques most popular, robust, non-invasive, having a huge database over 4 decades. So what are the clinical subtypes of heart failure? As you know, the heart failure are of 2 types. Heart failure with preserved ejection fraction, that is called HFpEF, is characterized by normal systolic function but impaired diastolic relaxation, resulting in reduced cardiac output. HFpEF is common in postmenopausal women, elderly with hypertensive or amyloidosis or whatever disease, infertility disease. But heart failure with reduced ejection fraction, as you know, very common, characterized by reduced systolic function, most commonly associated with ischemic heart disease, secondary to hypertension, diabetes, family history, smoking, infiltrative myocardial disease such as sarcoidosis, amyloidosis too. So what the clinician they need from us, that is called the category they have detection and diagnosis, we have to give them the etiology, whether it's a systolic versus diastolic. That means HFrEF versus HFpEF. What are the causes of heart failure? Ischemic versus non-ischemic. Exclude valvular contribution. Severity. They want to know severity, risk stratification, therapeutic guidance, ejection fraction, filling pressure like left atrial filling pressure, detection, evaluation of functional MR, LV hypertrophy, and pulmonary hypertension. Various nuclear techniques to assess patients with heart failure. Myocardial, as you have just heard from Dr. Prabhu, myocardial perfusion imaging with radiotracer used to differentiate an ischemic from a non-ischemic etiology of heart failure and cardiomyopathy. Just do a resting myocardial perfusion scan and you can differentiate between a cardiomyopathy of non-ischemic origin and from a ischemic heart disease. Developments in measuring quantitative blood flow. That is one of the bonding points and the very important point, PET, CFR, to provide an accurate determination of heart failure etiology. If coronary disease is established, MPI or PET scan are used for assessment of myocardial viability and identify patients likely to benefit from revascularization. In patients with heart failure who are not candidates for revascularization, myocardial remodeling often leads to poor patient outcome. So what are the various tests? Nuclear tests like what Dr. Prabhu has just mentioned here, shown Spec analysis of myocardial shape and desynchronous contraction by phase and amplitude analysis on Spec study or relaxation can re-stratify patients and may help to guide therapy. Then next important, very important is cardiac autonomic innervation by PET imaging, which I'll be stressing much more in today's presentation, should expand the use of radionuclide imaging in heart failure. FDG PET has recently been used for assessing, this is a new research area, new trials for assessing arterial tissue function, particularly its metabolism, left atrial metabolism in atrial fibrillation, which is a very common cause in HFpEF, in assessment of left atrial dysfunction by FDG PET. The trials are going on, researches are going on, maybe we'll get a very encouraging result in the near future. Then use of radiolabel tracers in monitoring stem cell transplantation. So coming to the positron emission tomography, as you know, it is a molecular imaging technique. It can give contractile function, myocardial perfusion, myocardial metabolism, myocardial innervation, inflammation, angiogenesis, cell death, and ventricular remodeling. It is a promising tool for understanding the physiological consequence of heart failure, resulting in early detection of patients with heart failure at risk, gives therapeutic strategy planning and treatment response monitoring, which you can do with PET imaging. So what are the non-invasive assessments? First, I am taking heart failure with preserved ejection fraction. Most probably it is a non-ischemic origin. What is the role of CFR, coronary flow reserve or myocardial flow reserve? Absolute quantitation of myocardial blood flow is an established method of quantifying the blood flow in individual coronary artery. Recent studies have suggested role of coronary microvascular dysfunction in HFpEF, heart failure with preserved ejection fraction. Cardiac PET is a non-invasive quantitative imaging modality capable of accurately quantifying myocardial blood flow reserve. The ratio, how we calculate the ratio of myocardial blood flow at peak stress to myocardial blood flow at rest. So here we calculate coronary flow at hyperemia with IV adenosine pharmacointervention with coronary flow at rest. So normal volunteers, the result of CFR is 3.6 to 4.2, but in CFR patient with risk factor 2.8, but CFR in patient with stable CAD 2.0. So calculation of CFR for each myocardial segment is calculated as the ratio of segments of myocardial blood flow value with adenosine infusion to the myocardial blood flow value at rest. Then CFR is myocardial blood flow during adenosine infusion divided by myocardial blood flow at rest. Normal range is 2.53 per minute per gram of tissue with a range of that. So here you can see that 45-year diabetic patients with a normal myocardial perfusion, you can see here, and CFR is more than 2.0, 2.13, you can see all. So more than 2 is normal. So this is a normal CFR parameter. Now I'll show you the abnormal CFR. So here now you can see there is a perfusion defect at the lateral wall here with a totally reversible, and this is a left circumflex territory, and left circumflex territory shows 1.29. This is much less than 2. So this is called the myocardial flow reserve with a known CAD with a HEP rep. So in patients without significant epicardial disease, myocardial flow reserve can be considered a marker of microvascular dysfunction and a surrogate for coronary vascular health. Myocardial flow reserve has been shown to have prognostic value in patients with HFpEF with preserved ejection fraction. Myocardial flow reduced in HFpEF patient compared with control that represent the microvascular dysfunction. HFpEF is associated with a lower global and regional myocardial flow reserve than non-HF patient. The mean global MFR is 2.16 plus minus 0.69 in HFpEF, which is significantly lower, compared with the 2.54 plus minus 0.8 in hypertensive control, and in normal training volunteers 2.89. So it can clearly detect the microvascular dysfunction resulting in LV systolic dysfunction in case of HFpEF patients. So this is a patient, so you can find that myocardial blood flow is reduced and all the territory is showing myocardial flow reserve is low, LAD 1.1, 1.1 and 1.4. So what is the Spec and PET tracers in patients with heart failure? In cardiac sympathetic neuronal dysfunction has been shown to be abnormal even in involved myocardium, which can cause arrhythmic events leading to sudden cardiac arrest and heart failure. So current guidelines recommend an ejection fraction more than 50% in patients with HFpEF with elevated natriuretic peptide BNP or pro-BNP levels and structural heart disease detection such as left atrial enlargement or LV diastolic dysfunction. The most commonly used Spec tracers, as you know, as you just heard from Dr. Prabhu, is a sympathetic iodine 131 MIBG, whereas the PET tracer, which has come, C11 hydroxyepidrin. This is the PET tracer, and another one is C11 CGP 12177, a beta adrenoreceptor antagonist, can visualize regional defects in myocardial pre-sympathetic innervation, can pinpoint effectively as compared to iodine 123 MIBG SPEC imaging. So, the cardiac sympathetic imaging and cardiac innervation. LV diastolic dysfunction is a characteristic finding in patients with HFpEF and increasing severity of diastolic dysfunction is related to heart failure progression. C11 HED PET imaging allows for improved global and regional quantification of sympathetic nervous system innervation using a semi-quantitative retention index, RI, using 17-segment model to calculate in different myocardial region that the reduced C11 HED uptake and delayed washout. The benefit of performing PET imaging compared with SPEC imaging is related because PET is more better than SPEC because higher spatio-temporal resolution, established method for kinetic modeling, and absolute quantification of radial pressure uptake. Here you can see there are two sets of images. First set of image showing the hypertensive patient and the retention index has been calculated. This is the Doppler echocardiography. This is called the left ventricular filling curve, that is a EU wave, and this is called the left ventricular atrial contraction. Here you can see the retention index is there, and here it is less severe. But here in amyloidosis patient, there is no uptake at all. So this has got a denervated sympathetic innervation up to a severe degree. So reduction in myocardial sympathetic innervation is impaired in the presence of HFpEF or advanced diastolic dysfunction. Grade 0 to 1 diastolic dysfunction with a retention index of 0.024 to 0.092. Grade 2 to 3 dysfunction, which is severe, that is retention index is 0.0182 to 0.075. Normal volunteers 0.0282 to 0.123. Reduction of C11 HED uptake retention index is associated with the presence of various grades of heart failure with preservation fraction, that is called diastolic dysfunction 0 to 1. The 2 to 3 degree could lead to a new approach to detect the progression of diastolic dysfunction in HFpEF patients. The effect of medical therapy targeting sympathetic function in diastolic dysfunction in HFpEF patients can be monitored. Can be monitored especially for prognosis as well as efficacy of medical therapy. So here you can see the non-ischemic disease. Here you can see the retention index. So here the HFpEF with a less LV diastolic dysfunction 0 to 1, the retention index is very good. But as compared to diastolic dysfunction of 2 and 3 grade, the retention index is very low. Cardiac sympathetic neuronal dysfunction has been shown to be abnormal even in viable myocardium, which can cause arrhythmic events leading to sudden cardiac arrest. So you can say that C11 hydroxyepidrin, the beta adrenoreceptor. So I will show you the image which will be better appreciated. Here you can see the cardiac sympathetic iodine 131 MMB is showing a defect here, but the perfusion is normal. So this patient definitely needs a ICD for the future treatment planning. So here the mismatch perfusion with the sympathetic innervation defect. Role of PET scan in assessment of myocardial viability in HFrEF, that you can see that viability direct revascularization would improve cardiovascular outcome, as you know, reduce heart failure symptom, reduce admission to the hospital, and improve quality of life. So the amount of viable myocardium should be 20% or more, so that the patient would get benefit. Here there are two types of imaging, either perfusion and metabolism. Then here you can see the perfusion is there is a defect, resting perfusion defect, and there is a metabolism in the anterior and apical segment, so showing the viable myocardium. Here you can see the match defect, perfusion defect, and there is no uptake in the FDG. So this is a match defect of a scar tissue, which will not get any benefit out of revascularization. This is a patient of heart failure patients with, and we found and we calculated the ejection fraction at 21% with severe degree of hypokinesia. And here you can see the amount of perfusion defect here in the anterior septal wall and showing viability. So 22 ejection fraction showing viable myocardium. This patient was subjected for a bypass surgery, and now the patient is doing very well. The ejection fraction is improved to 38 to 40% now. So role of PET scan in remodeling HEPREP. So remodeling may be adaptive in early phase of cardiac injury. Continued remodeling is a pathological process. So matrix metalloproteins, MMP, are a family of proteolytic enzymes involved in the degradation of myocardial extracellular proteins in adverse modeling. So left ventricular remodeling may be adaptive. So, what we can do, atrial fibrillation is a common arrhythmic event, complication patient with heart failure. In patients with end-stage heart failure, left atrial and ventricular MMP and collagen levels are higher in atrial fibrillation compared to patients with no atrial fibrillation. What are the radio tracer for ventricular remodeling? Indium-1 level MMP, technetium-91 MMP, then alpha-beta-3 integrin PET tracer, F18 fluorescein also provide novel information about the myocardial remodeling process. It holds significant diagnostic potential in vivo localization MMP activation, where you can see the thallium perfusion showing the perfusion defect here, the MMP laboratory technician showing. So more you see the activation of MMP, the more remodeling and more severity of the heart failure. So this is the American Heart Association treatment goals: healthy lifestyle, prevent vascular coronary disease, prevent structural abnormalities. You have to do absolute flow quantification, myocardial blood flow. So if you want to know control symptom, gated PET, LV function, improve HRQL, perfusion viability imaging, prevent hospitalization, control symptoms, reduce hospitalization, inflammation imaging device. Then the last slide is advances in the application of cardiac PET may play an increasing critical role in diagnosis, prognosis, and clinical treatment of cardiovascular disease. Molecular imaging approaches using PET could evaluate myocardial pathology at different stages of heart failure, HEPEP as well as HEPREP. PET imaging procedures would answer the questions such as etiology, severity, reversibility of LV function, and prognosis. The development of various therapies, especially cardiac device therapy or angiogenesis or stem cell therapy, will require a combination of imaging and monitoring therapy, which would facilitate better clinical outcomes for heart failure. Thank you very much. And we hope that by April, we would like to hold the 3rd World Congress in Cardiac Imaging and Clinical Cardiology in Mumbai at Tajlands, Bandra West. Thank you.